the fundamental, compass here, our North Star is what is best for the human, right? Inside of all this are people doing this work. And we have to figure out how to give them better tools and better environments to do this. Because why would you do this and get paid what you're getting paid if you know the system's broken, you can't fix this, and this is hurting patients? I mean, a lot of people are going to carry that moral injury with them. And so I think, this goes back to why we do this research.
From the basement to the boardroom, from ideas to innovation, you're listening to the Beyond Clean podcast, the central nexus for the people, processes, and products that are pushing the sterile processing industry forward. Each week, you'll encounter diverse perspectives from subject matter experts across the country and around the globe. Frontline technicians, CEOs, engineers, and entrepreneurs with a common goal to help you fight dirty. Every instrument, every time. Whether you are tuning in for education or inspiration, we're glad you're here. Now, turn on those washers and turn up the volume. It's time to go beyond clean.
On this episode of Beyond Clean, we're speaking with a good old friend, Dr. Peter Nichol. And a reminder, he goes by Peter, and he's done an enormous amount of research, and he's a pediatric surgeon, surgical director for OR services at American Family Children's Hospital. And he also has been working closely with Beyond Clean. Really, I want to say we're almost pushing back 6 years, Hank.
Right. It's been a pleasure introducing Peter to the industry and, getting to know him and his passion. And really pumped today to talk about all the research that he's continuing to push forward and, give a little insight into how that happens, why it happens, the impact that it's going to have, and how folks like you and me can throw in and contribute in our own way to bring it forward and actually make the changes that are so frustrating in our careers, in our hospitals, and across the globe.
All right, don't go anywhere. Coming up next, Dr. Peter Nichol. I'm Justin Poulin.
And I'm Hank Balch.
From 17 Studios, you're listening to Beyond Clean, the global voice of sterile processing.
We're speaking with Dr. Peter Nichol, pediatric surgeon and surgical director of OR services at American Family Children's Hospital. If you've been listening to the Beyond Clean podcast for a while, you will know that Dr. Nichol, or Peter, don't call me Dr. Nichol.
Don't call me Dr. Nichol.
Is not a first-time guest here. And so, Peter, it's great to have you. It's been a little while. I think the last time we had you on, you were doing some research, and we got kind of an update on some of the findings of that research. And that was, I think, your second appearance. Obviously, you were at one of our conferences in person and presented with us back in Indianapolis many years ago, amazingly, before the pandemic, which it just seems like another life at this point. But welcome back to the show. And this whole season, I'm sorry, but you're not going to be a standout. You're going to be one of 8 surgeons that we talked to this season.
Hey, I'm happy. Welcome to the party to the other 7. It's about time.
Well, you're definitely a standout. I say that tongue in cheek because you were one of the first people to take just such a great deal of interest in sterile processing. It's how we got connected with you very early on. And the reason you did the presentation is you've been really set out to fix a lot of the pain points that our listeners are going through every single day. And so just on behalf of everybody that's out there, I think we all want to thank you for, being an early adopter of, hey, wait a second, let's see if we can get some high level interest. Why don't I go down, get in the department, see what it's really like, and learn this, to the benefit of the industry?
Thank you for that kind introduction, Justin.
Yeah, Peter, of course. It's very deserving. And speaking of that research, why don't you just kind of give us an update on where you're at with the research today and how you've continued to develop that project out and continue to get more findings and actionable insights?
So for those of you who have not heard me before, and those of you who have, you know that what has driven this is a fundamental interest in the plight of the human in terms of healthcare delivery. And when we go back to my very first podcast, which was, I think, 2018, 2019, I said, listen, the people working in sterile processing are actually healthcare workers, right? They are delivering instruments that are intimately involved in the care of patients. And that has been really sort of the moral center, the moral compass, if you will, of a lot of the research we've done. So to update you, I think we talked about this the last time, we collaborated and sent out 3 surveys. One was on education. What's the educational background of people working in sterile processing? The second one, which has turned into really quite a monster, and I mean that in a good way, was an economic survey. And the third one was a safety survey. And then additional work that has been done by my group, which is now called the Surgical Procedures, Advanced Research Technologies and Analytics Group, or SPARTA group, has been on looking at the rate of error in terms of instrumentation. So what's missing, what's broken, what's dirty, and then also examining the workflows in sterile processing to model where the errors are occurring and where do we need to make interventions. So I could summarize the work for you, Justin. We have one paper now that is in submission. That's the education paper. And what it speaks to, if I could summarize it, is that there's really a lack of any kind of coherent, and we know this, curriculum around sterile processing. Yet we find in this survey where we sent it out to 50,000 people, we got 1,000 responses, which is pretty good. 1,000 responses is a lot of data. It is a highly motivated, conscientious group of individuals that are thirsty for education and improving themselves. The average person in the field of sterile processing, regardless of rank, is doing list searches or doing their own online research, trying to figure out how to solve problems at least on a monthly basis, if not more frequently. And they are highly motivated to get additional training and get certifications. I think 94% or 96% of the respondents had at least one certification. Yet they're doing all this with really minimal support from their institutions. They're not getting any real significant support in terms of leadership training. When they do, that's when they seek leadership training. And as you know, when you're heading a department of 90 to 100 people and there's a fair amount of turnover, you need leadership training. In summary, it's the education paper, which will hopefully be coming out in the next several months, since the mission is being reviewed right now, will lay all that out for us in terms of defining this population of workers. So a very important workforce. The economics survey, we're starting to put together papers on that. So there was one survey, but we're going to have 5 papers at least. So we're looking at the impact. So what is the baseline demographics in terms of what are people getting paid? And what is the influence of unions on salary? And it seems to have a benefit early on at entry-level positions, but that doesn't really carry through. And unions don't seem to really have an impact in terms of helping with job advancement. They don't do a whole lot in terms of benefits. And we have other stuff looking at economic data of personal well-being, so the amount of debt people are carrying, the amount of savings they have. And, it's a financially very at-risk population. I mean, these people are doing incredibly important work in a very complex environment, and they're really not being paid what they're worth.
I remember on your last podcast, we talked about how hospitals, have an obligation to do no harm, right? And to serve their communities and the health of their communities. And you talked about how many people are being employed underneath the poverty line, and that is a key indicator for somebody's health and, a future predictor of their health. And so, quantifying that, I think, is important. And another thing that I remember is the presentation that you did, and you've done it several times, but I think the first time was at Stanford Children's at a conference where we spoke together. One of the things that we talked a lot about was the fact that when you went to look at peer-reviewed journals, There was no information. There was so much on diabetes, and there was nothing in this space. And yet you identified those economics. So what's the deal here? I mean, honestly, as you've gone into this and you've done more and more research, and you had a history of doing research before you got into the sterile processing space, but we've never really asked you the question, why is it taking so long to get this in-depth research going and having it done on sterile processing? Like, why diabetes so much and sterile processing so little?
Yeah, so some of that is going to do with funding, right? And what drives publications is one hand washes the other. But if you want to get grants from the National Institutes of Health, then you have to publish a lot. And if you get grants, you're going to publish a lot because you want to get more grants. And the National Institutes of Health lays this out as they have the NIDDK, which is one of their 26 institutions that is focused in large part on diabetes. And there's money set aside from the federal government. So that's clearly part of it. Now, that being said, there's a lot of research that goes on that it is peer reviewed and is not funded and is clinical outcomes based. And so I think part of it has to do with, at least with surgeons and most people in academic medicine, is you're trying to publish in areas that your peers are interested in, because if you're in academia, a university setting, you want to get promoted. And the way you get promoted is becoming nationally recognized for something. And the best way to get nationally recognized is to be an area that a lot of people are studying and then to be publishing in that area. So you get invited to give talks, and people can say, well, this person's got a national presence or an international presence, and we can promote them because of this expertise that's recognized broadly. So I think part of it, Justin, is just nobody's ever published in this area. Then there's a cultural thing. I think, sterile processing has kind of grown in a very, and I don't mean this in a bad way, but truly it's kind of like mushrooms. I mean, we sort of treat this area like mushrooms. We stick people in the dark and on them and expect them to grow, right? and so the business as usual in the hospitals, you stick this stuff in the basement, you don't worry about it. It's just the cost of doing business. And we don't have really great business people with systems engineers looking at how do we make healthcare look more like other industries where it's much more efficient and safer. And I think once we start seeing more of that, we're going to see more interest in this area, and you'll see more publications and people trying to share information of how do I improve sterile processing to improve the efficiencies and safety of my hospital and my ORs.
I've never heard that analogy before there, Peter, but it makes a lot of sense with my experience. So I think I'm going to carry that here with me moving forward. As Justin mentioned, you dove into this as early as 2017, 2018. And to your point, there's all these reasons that people have not looked at it in the past, but now you're in it deep. And I'm really curious, now that you're seeing all the nuances here, what are those major drivers that if more surgeons were aware, there would be more people, there would be more research? What are those topics or themes that have come up that you think could really bring a tremendous amount of value to the patient and also to the surgeon population that we're serving as sterile processing professionals?
I think really what's going to have to happen is it's not going to be the surgeons. The surgeons are an end user, obviously, and we have to convince them how this makes their life better. But, I can tell you, dealing with some of my own surgeons at my own institution, they're very entitled and they don't have time for this, even though I have wonderful data that would help augment their practice and make things better for them. So there's resistance to change. So I think what will be one of the major drivers is you'll see some high-profile healthcare leader for some major healthcare organization, whether it's Kaiser or it's, Advocate Aurora or maybe even UW Health, I don't know, is going to come out and say, look, this is something where we're losing millions and millions of dollars a year, and we have to improve our capacities, and we don't have the infrastructure to improve our capacities. So we're going to have to have an integrated approach to how we improve this and study this. And I think once that happens, you'll start seeing the floodgates open and a lot more publications, a lot more interest in this area. And it is part and parcel of how do we deliver more and better with the resources we have? Because essentially what COVID has taught us, or taught me, is that we've become Canada. We're just a lot more expensive. But we can't get patients into hospitals. We're not efficient. The waiting lists are very long, and they're probably as long as they are in Canada. but Canada is nationalized healthcare and they're not paying as much money. We're paying 2-3 times as much and people are getting same or worse quality care in the same time frame. So if we're going to fix that and we're going to improve our capacities particularly in the ORs and do more cases with the same number of nurses and nursing staff and the same number of ORs, we've actually got to improve our delivery and our efficiency of delivering instruments and I've said this from the beginning, give the surgeon exactly what they need when they need it for the right patient. So right instrument, right operation, right patient, right surgeon every single time. And no waste. Yeah, that's the only way you're going to get to it.
And, that's a theme that has come up a lot in the last 5 years for us of just being willing to come out there and say, hey, y'all, the process is broken. I don't know what you're assuming is going on in these hospitals out there, but, it ain't working. There is waste, there is error, there's quality breakdowns, and it's systemic. It's not just the big facilities that make the front page. It's really broken from top to bottom in all the reasons that you're describing. And I completely agree that that's what's going to drive it is.
But I want to get back to this is, so based on what we've seen in our surveys and how much people in this space, how hard they work and how much they care about their job, a lot of people leave because the moral injury of knowing the system's broken and they keep trying to roll the stone up the hill and it keeps rolling down. And so eventually like the burden of that, like, I can't stand this anymore. This is not sustainable for me because we're giving them instruments because we don't have the resources we need is driving people out. So remember what I said, the fundamental, compass here, our North Star is what is best for the human, right? Inside of all this are people doing this work. And we have to figure out how to give them better tools and better environments to do this, because why would you do this and get paid what you're getting paid if you know the system's broken, you can't fix this, and this is hurting patients? I mean, a lot of people are going to carry that moral injury with them. And so I think this goes back to why we do this research.
Yeah. Peter, I can't tell you how much I appreciate that center as the North Star, as the compass, right? Because there's a lot of other reasons that people, even if they got into this research, like they're fundamentally looking at efficiency, they're fundamentally looking at cost savings, they're looking at revenue. At the end of the day, though, there's people on all sides of this equation. There's people in sterile processing. There's a person under the drape. There's a person who's a surgery, like all that moral injury that you talked about, like that impacts every single person in that surgical workflow. And I think it's very important to keep it at the front of your research. And it's going to come out of your research in how you write, where you publish, and how you continue to talk about that. But I want to get here to a process piece, because sterile processing, we're not introduced to research. So as an individual, right? Like I started as a technician, ended up managing, directing. I don't know anything about this deep peer-reviewed research that you're talking about. Can you just explain like what that process looks like, from the idea of, hey, there's a problem here, we want to get more information about it, and then walk us through just what that looks like, and then maybe highlight, some of the challenges for it's not as easy as it may seem of, hey, they did some research, they wrote a paper, bada bing, bada boom.
So I'm glad you bring up that people do research for different reasons. So let's start there. So I'm doing this because I want to fix this problem. I made this very clear to you guys when we got involved in this. I've been very clear with anybody who gets involved with me, like you either want to fix this or you don't. And if this is about something else, you're wasting my time. The way peer review works is that you're going to write a paper. You're going to be doing either qualitative or quantitative research. We do primarily quantitative research. So that means dealing with numbers. So when we put out a survey, we get 1,000 responses, right? And so then we analyze this, and I've got a statistics platform that the data gets uploaded to, and then I go and play with it. And then I have a statistician analyst who, I tell them, look, these are the things I'm seeing. I need to know if there are significant correlations between, how much money somebody's making and whether they're a unionized facility or not, whether they're a certain threshold for when they have credit card debt or not, savings or not. And can you show me there's a statistical correlation? And then I try to write my papers in a way that's in common English so that anybody can understand them, and try to give real world analogies in my discussion. So in a typical paper, you have, an abstract that sort of lays out what the paper's about and gives you a summary of the results. And then you have an introduction that lays out the scope of the problem. And then your methods of how you collected the data and analyzed it. And you have a results section where you report the results of gathering all that data. And then a discussion where you give your sort of thoughtful analysis and describe nuances around the data. And then that gets submitted to a journal, and the editor looks through it and then may ask you for reviewers, people who have expertise in this field, or they may have a stable full of reviewers, and they'll usually send it out to 2 or 3 reviewers who will read through it. And they give you about 3 or 4, they give them about 3 or 4 weeks to review it, and then ask for comments. And it's, accept, reject, or we need more information. You have to make some adjustments, some corrections. There may be some typos, maybe some further analysis that's requested. And then it gets published. And then once it gets published, depending on who's interested in it, other people will read it. And, what you hope is going to happen is people get excited about it and other people start doing research in this area. And eventually somebody's referring to your original paper saying, well, Nichol et al. Showed that, the economics of sterile processing is this. And we decided to do some other analysis around this. And that's how it grows. That's the peer review process. But what I will tell you is I think that, and I try to be very inclusive and democratic about how I do this. Cause, you and Justin are going to be authors on all 7 or so of these papers. It's important to get a ground level view. It's important that you have input from the people who are in the trenches and making decisions day to day to help guide you so you understand what you're doing. Otherwise, you got a 30,000 foot view, and a 30,000 foot view is never good. And we know that from, military, for example. Like we know our soldiers have great autonomy in this country. And that's why we have such a great military. I think you have to have the same sort of mentality around this in sterile processing. It doesn't mean that everybody who's in sterile processing needs to be publishing. But if there are opportunities to involve them, that should be happening because they're going to have, they're going to have insights into what's going on. And it's just like, if I want to really know what's going on in an OR, I don't go talk to the surgeon. I talk to the scrub tech. Scrub tech's been watching everything, working with that surgeon, responding to every single move of that surgeon, totally aware of everything, very conscious of it, of the stuff the surgeon may not even be conscious of. That's what I mean by talking to people in the trenches.
Yeah. What are those challenges then? Like you gave a great outline of the process, but then in the midst of that, like what are the things that people maybe don't plan on or, causes it to slow down or causes it to, derail?
So I can only speak from my own experience. Well, and I'm not going to talk about my basic science experience in molecular biology and developmental biology because that's not relevant here. But in this particular space, one of the hardest things to do is, like let's take our study looking at instrument errors and how we went about doing that. Okay. And hands down, the biggest challenge is you're relying on human beings to record the information. So we had to train up 24 undergraduates to go into the ORs to capture information on instrument errors. So we had to tell all the surgical technicians when to cue them in. And there's a fundamental rate of human error. And so the tech's distracted, they may forget, right? You have variable skill in terms of the observers and variable levels of how aggressive they are in terms of seeking answers and variable levels in terms of how fastidious they are in recording this stuff. So one of the biggest challenges is the actual data collection itself. Okay. So as opposed to a survey, the big problem with the surveys is that if you've read the survey correctly and you send it out to 50,000 people and you get 1,000 responses, you're like, well, why didn't I get 10,000 responses? Right. But surveys are pretty idiot proof most of the time in terms of your data collection. Like the data you get is going to be pretty solid. We had very few questions where we had problems interpreting the data, the responses. But when you're observing stuff, you're relying on human eyes and human judgment. So hands down, the biggest challenge, like when you're looking for instrument errors, it's much better to stuff be automated, right?
If you're looking at errors and you have to be concerned with the errors in the data collection as well, so that we can't get away from those danged errors.
Hands down. Right. No. So the biggest issue is not around something missing. That's pretty easy, right? Something's missing or something's not working. That's easy to pick up. It's when is something contaminated or not? Where is their bioburden? Like we have really terrible optics on that because, and that's the irony of all this, and you pointed out, is The biggest caveat to doing that kind of research is that what comes out with errors is that in terms of instrumentation is the inspection process is very flawed because human beings are doing it. But reporting on the inspection process was done with human eyes. So there's even an error rate in terms of detecting the errors. So I know we're underestimating error rates, particularly around stuff like bioburden, because we don't have an automated way of doing that. It'd be much easier to inspect every instrument before it goes to the OR and have that automated. And then all I have to worry about is it, and actually you could figure out whether things are working or not, right? You can develop visual proxies for that by inspection, automate that. And you can also, you look at layer jot. You could figure out, is everything in the pan that's supposed to be in the pan, right? Are there errors? Like all those things, I could eliminate the human being. And by the way, if I wanted to do a year's worth of data collection, it's going to cost me probably $2 million in human resource, right? Whereas I could get a software program and a bunch of inexpensive cameras and probably do this for a tenth of that, right? And get much better data and get the compendium of all the data on all the instruments and not just what happens between 8 and 4. So that's the biggest challenge for sure.
Yeah. So you're actually getting at, some of my next question, like you mentioned earlier that one of the common reasons to do research is to get promoted or you increase in your own like career growth and career ladder. But obviously there's an innovation component as well. And I'm just kind of curious, in the research that you're doing, that you're a part of, obviously, like you have got that human connection as the North Star there. In sharing and publishing in these peer-reviewed journals, like what is the industry impact that you're expecting? And then what is the industry impact that you want? Like, what do you want people who are going to be reading these papers to do with your research and then continue to move the ball forward?
So I would say that the impact I would like to see if you look at the survey data is that it actually affects federal policy. That the Department of Health and Human Services, DHHS, looks at this and says, you know what, we got a problem here. We actually need to start working with the Department of Education and figuring out a curriculum around sterile processing because there's a worker shortage and there's clearly an uneven, and it's a patchwork in terms of states, in terms of who requires education, who doesn't. We need to actually have make this a national priority for patient safety and for healthcare, because healthcare is so expensive. I mean, it's 20% of GDP and people still aren't getting access to it, right? Like we're Canada, only are more expensive. So I would like to see the economics data, the education data, and the safety data. I would like to see that have an impact on a federal level with regards to policy. That is my target audience, hands down. Okay. And then I think around the actual measurement of utilization and instrument function and instrument errors, where I want to see us going is I want healthcare to finally start adopting technologies. And I want to spur other people to do this as well. Borrow other technologies from other industries and bring them into healthcare to make it more efficient, to make it safer. And I keep pounding away on this. If you do that, you still need human beings to run everything. Okay. You start elevating the work, right? We're not going to have more workers. We just know that. And the boomers are going away. And you look at what's happening in Japan right now, and the Far East is older people are working longer, right? We have to do this. There's not more bodies coming. And this is where unions fall down flat, is they don't think about how do we innovate this space because we know the work is going to change. What we need to do is we need to make the work change. We need to elevate the work. We put the human being on top of that, and we make it an informatics-driven process so that they have to go get technical training so the pay is better, right? So the data that we're generating around errors and around utilization, which we hope hospital systems will recognize and say, hey, we got to do this. We're losing tens of millions of dollars a year, and it's affecting our ability to deliver healthcare. Okay. Is going to invite in industry in a very organic, holistic way to start taking visualization technologies and stuff like this and change the space to make it better. And then you got to train people to use that technology, and then jobs get better. So again, we're back to the human being and our North Star here, right? That's the target audience. That's what I want. And I will say this. I know I'm getting over my 2 minutes for this answer, Hank, but I went to Northwestern back in 2018 for a week for a leadership course for the Society of University Surgeons. And every single professor that got up there, these are people who are much smarter than me, said, you know what? Healthcare is the most complex business model in the world. None of us understand this. I'll tell you this. I know enough about healthcare that if you can bring these technologies in, it starts to look like a lot of other businesses. Okay. And you start using the same kind of metrics. And yeah, it's complex. Not going to lie about that. But if you have, if we take sterile processing and we can fix the visualization problem and bring in the informatics, it starts to look like a lot of other high-end manufacturing industries. And you know what? That model, you can iterate on any number of things in healthcare. And now it starts to look like any other high-end, technology business.
Okay. So as we're wrapping up, Peter, we like to really give people.
We're almost done. You're kidding.
Oh yeah, you blew through it. Yeah, well done.
Okay.
Where does the time go? Anyway, I saw a great meme earlier today. It said, "Wait, when you realize that 3 years ago wasn't 2017?" That one made me laugh. So here's what we like to do. We want to motivate people to get involved. We want to fuel that passion instead of constantly rolling the ball up the hill and having it roll down on them and being frustrated. And one of the ways to do that is, to let the audience know what they can do to do their part. And when it comes to research, I would imagine most people out there are going to be at a loss of what they can do to help promote research, push it forward. I know there's many that are listening that have maybe been involved, but for the most part, I'd say most people don't really know. And since this is a season where we're speaking to surgeons, I would like you to get very prescriptive here with one or two takeaways for our audience where, what can they do to help be a part of further research in SPD, and how can they encourage not only surgeons, but their clinical user counterparts in the operating room to also prompt their own research, maybe get studies around things going that would be important for them or that they would see as important?
So the first thing that comes to mind, Justin, to get them directly involved is we could use Beyond Clean's platform, an email list, in a very creative way to crowdsource ideas for further surveys about what's important to people. I'd be happy to entertain that and help anybody who wants to do a survey that we think could get published. I mean, not all the ideas are going to be good, but some of them will probably be really good. Again, getting back to the people who are in the trenches probably know the most about what's going on, right?
So one takeaway is if we send out surveys, be part of them so that they have the kind of merit and size and population to move decisions forward. And if we're asking, what do you think would be a good survey, or what surveys do you want to be part of? Think about an answer there so that we have a lot of options for furthering research. Is that correct?
Well, I think it's actually the latter. I mean, I absolutely encourage everybody to participate in surveys, but I think if we crowdsource ideas for what types of surveys to do next, and understand, like I got a small team, so there's only so many I can publish a year. Okay. But, I'd be happy to work with anybody who can come up with a good survey idea to get a survey out on Qualtrics, and then we can email it out on our email listserv and get engagement. I would guess that, you'll get a lot more engagement if it's, you have participation of people who are actually, in the trenches on the front lines. So I think that'd be a great way to do it. If they have colleagues that are, in the ORs that they want to engage or are interested in engaging, or I'm happy to talk to anybody. I really am about this stuff. Well, I'm at a point in my life where I'm 55 and I just want to solve the problem. Like, this is really all that matters, is we got to solve this problem. And eventually it will get solved, but I'd like us to solve it. We are the first ones here, and the only way we're going to do is we have a lot of people participate and get buy-in.
So you said you were happy to engage and hear from people. So why don't you tell everybody how they can contact you?
Yeah. Okay. So it's Peter Nichol, Nichol 19 at, actually, what's my email address on,
it's so simple. I could have done it for you. Peter at beyondclean.net.
There you go. Do that one. That's easy. Peter at beyondclean.net. Yeah.
And then also connect with Peter through LinkedIn. That's how we found Peter way back in 2017 because of his content and conversations on there. And, to kind of bring this back around to the very beginning, a lot of we're talking about specific peer-reviewed research and everything else, but a lot of these conversations can happen and are happening just in the public networking space. And people are engaging with ideas and we're getting inspired and encouraged because we know these things are going on. But it's not the only thing that needs to happen to push the industry forward. So just connecting with guys like Peter and other folks out there on the clinical user side, that are inspired and encouraged and passionate to make a change, like all that can happen today. And it just takes a little connection request through LinkedIn to get it started.
It's true. Yep. Happy to hear from people.
That was Dr. Peter Nichol, Pediatric Surgeon and Surgical Director for OR Services at the American Family Children's Hospital. Hank, that's appearance number 3. I think that's a new record on the Beyond Clean podcast. Peter leading the way not only in research, but also in appearances on the podcast. And I think the number one takeaway for me, and we didn't really discuss it, but I think it's really important to note how long it takes to get research done. And so the faster that we can push this research through, the closer and the quicker we can get to put in some federal legislation to really move the needle. And so, honestly, we had a couple of takeaways at the end there, but we really are going to have to continue to drive this research because this could be a decades long process. It could span generations, honestly. And we want that to happen a lot faster because Peter said, I'm 55 and I want to solve this problem. I'm figuring, he's probably got 30 life years, but only 10 more work years. And we need to maximize our time with Peter too.
That's a great call out. Like this initial survey was done in 2020. So we're 3 years in now. Now, of course, COVID slowed down a lot of that process, but it's not a quick process. And it's easy for people to take their eyes off the ball, to give up and, start focusing on something else. But the fact that Peter's sticking with this, that's where change happens. That's where momentum happens. It's just people who are not going to give up, who have caught the bug. They become passionate about it and they're going to take it across the finish line no matter what. But like Peter said, my big takeaway is he's not doing it by himself. We can't do it by ourselves. We need all the listeners out there from every corner of the globe and the industry to pitch in with us. If it's ideas for surveys, if it's completing surveys, if it's actually doing the research, this is a team effort. It's going to take all of us to fight the dirty better across the globe.
All right, Hank. Well, I know that ends the episode, but it doesn't end our closing. I want you to tell everybody the best way to find Beyond Clean, how to reach out to us, why we want to hear from them. Tell them.
The best way, Justin, is to download the Beyond Clean mobile app available on Apple and Android devices. Apple if you're cool, Android if you're not. Either way, even if you don't want to download the app on your phone, you can still track us down on anywhere that podcasts are heard and leave us a rating and review 5 stars or just don't do it unless it's going to be 5 stars and tell everyone why you love Hank the most instead of Justin. No, just kidding. Show some love and tell your industry peers why you like listening to all the wonderful education and conversations that we have on Beyond Clean. Connect with us if you've got ideas about future guests or topics, info@beyondclean.net. And as we say around here at Beyond Clean, keep fighting dirty.